Hello, and welcome to the Osteogenesis Imperfecta Foundation's monthly podcast. My name is Tracy Hart, and I'm the CEO of the Osteogenesis Imperfecta Foundation. Each month, the OI Foundation brings you information about the diagnosis and treatment of OI presented by an expert in the field of OI and rare bone disease. The podcasts are a part of the ongoing educational effort of the newly formed Brittle Bone Disorders Consortium, part of the National Institutes of Health's Rare Diseases Clinical Research Network. The professional education activities of the BBDC are led by the Osteogenesis Imperfecta Foundation. Our podcast today will focus on surgical updates on treating children with OI. We're very excited today to have with us Dr. Richard Kruse. Dr. Kruse is the co-director for the Multidisciplinary OI Program, the vice chair of the Department of Orthopedics, and chief of the Orthopedic Trauma Service at Nemours A.I. DuPont Hospital for Children in Wilmington, Delaware. He is also professor of orthopedic surgery at Thomas Jefferson University College of Medicine in Philadelphia and the Uniformed Services University School of Medicine in Bethesda, Maryland. Dr. Kruse is also a member of the OIF's Medical Advisory Council. So welcome, Dr. Kruse, and thank you so much for being with us today.
Oh, thanks, Tracy, for having me. I'm excited to be here.
Great. Well, we're going to just dive right into questions, and I think the first one that I think we'd all like to know is what types of surgery are commonly needed by children who have OI, and what are the goals for those surgeries?
Well, that's probably the most important question you could ask is, first of all, the question that I'm often asked is, because I have OI, will I need rodding surgery? And the answer is a resounding no. Just because you have osteogenesis imperfecta does not mean you're going to require surgeries. The surgeries are specified depending on the type of children. Many children have progressively deforming or crooked bones or bones that break a lot easily, as we all know. So those are the children who can benefit from the surgery. Having said that, the most commonly bones that are broken or that require surgery are the lower extremities, and it's most common for us to consider surgery for the femurs, the tibia, and the lower extremity bones. Over the years that I've been doing this, we are developing a much increased interest in upper extremity function and surgery, and are finding that this is an exciting new area where we're able to help children improve their function. The goals of the surgery are the way I ask that question to myself is, how can I contribute to this child's overall development? How can I keep this child to be maximally functional, whatever they are able to do, to meet all their goals? So it's a very individualized question when you ask what are the goals of the surgery. Certainly we'd like to decrease the fracture rate, which the surgery can do. And certainly we'd like to decrease the deformity or the crookedness of the bones, which the surgery can do. But the ultimate goal of surgery is the child's development. So we try to tailor all our decisions on, will this affect the child's overall development, and will this help the child? I'd like to just mention along this line, I had a very recent discussion with a family on a child who had a fairly severe osteogenesis imperfecta and fairly curved femur bones and tibia bones. His lower extremities, he was not able to independently ambulate or walk, but sat very well. And the mother's very realistic concern for this child was, if I straighten the leg bones, will he lose his ability to sit, which is the way he depended on it, and scoot, which was his preferred mode of ambulation. So we had to address those issues with the surgery and discuss this right up front. So this example represents a very, very important point, is that we don't just look at straight bones. We consider the whole child for how to improve their function and address the child's and the family's concerns for that individual child. So that's pretty much the initial thing on the goals.
Well, and it's excellent, and I noticed that you use the word "we" a lot. Can you talk about that interdisciplinary team you have there? Because I know that, you talk about the family, but there are also other members of the team there that you work with, right?
Exactly. It's a team effort, starting with the family. And we'll get more to that later. I've learned a lot of that over the years and continue to learn. But yes, surgery is but one part of the child's care, and it's actually a small part. I don't say that lightly. Surgery is obviously a very traumatic and a very severe experience, but the child needs to be prepared for the surgery developmentally by physical therapy, proper medical management through pamidronate or zoledronate or whatever the preferred medical management is, and it involves occupational therapy, physical therapy. It's a large team, social work, and working with the schools. So it's a real team effort. And the more those pieces are lined up before anything is done, the better it is. What I've learned, one thing I've really learned and continue to, I have markedly expanded my work with the schools, because in our area there are a lot of different school districts, and I find that getting with the schools up front to get a plan going has really been helpful, because schools are different on what they'll allow children to do, and that's extremely important to understand before you undertake any surgery. Will the child be able to go to school? How will they get there? All these day-to-day needs that we don't see on the operating table itself.
That's right. That's great. And when we're talking about children, we're talking about the child having surgery. What age are we talking about, Dr. Kruse? Are we talking about, kids that will have surgery at the time they should be walking, or what is your philosophy?
Well, my philosophy is an overarching one of, I would like to have the child as much as able meet their milestones with their peers. Now, what I mean by that is if a child has the potential to independently walk or ambulate, we try to do that about the time they're supposed to ambulate or their peers will ambulate with non-OI. So that means getting them up maybe in braces, preparing them or something like that, or getting their bones straight so they can walk. So that's the overarching thing. It's nice to try to wait to do surgery, because larger bones, if the children need bone surgery, larger bones are easier to operate on. They tend to be stronger with prolonged medical management in today's world of pamidronate and bisphosphonates. So that makes it somewhat easier. So age and time help us, but I personally do not put an age limit on the surgery. I will have a surgical discussion with the family when it's perceived that the child needs surgery. And usually that comes down to, number one, are they having repeated fractures that we can't get control of? Is the child having persistent pain? Is the child having progressive deformity of their bones that's impeding their development or their function? So those are the kind of the linchpins to deciding on surgery for me, or at least initiating the discussion.
Okay, very good. You mentioned, rodding surgery. And so what are the special considerations a surgeon needs to review when treating a child who has OI, like plates and screws and casts? And, what are, families will hear all kinds of words associated with surgery. And so can you sort of break that down for us a little bit?
Sure. Yeah, and it's exciting in today's world as we have a lot more options as surgeons for the type of implants we use, to implants or devices we put in or on the bone to help hold it to be straight. That's exciting, but that's not so much the issue. The real issue is, I like to say that just like every child has a personality, every bone has a personality itself, and I sincerely mean that. Some bone is soft and some bone is hard, some bone is crooked, some bone is straight, some bone is straight in one spot. So every bone has its own personality. So I personally really use that to determine the type of implant that I will require to achieve the goals of the surgery. The best stability in any bone, the best holding of the bone, the best help for the child is to try to put a rod inside the whole bone. Now, these rods usually are used inside the bone, and as you probably know, the most common one is the Fossier-Duval rod, which is an expanding rod. It can fit in most bones. However, in smaller children, the bone may be too small. The shape of the bone may not accommodate a specific rod. So we have different metallic rods that we can put inside the bone. It's very exciting in today's world that we're working more and more on supplemental fixation. I've worked quite a bit recently on supplemental fixation of rod surgery by putting little metal plates, like a little slide. When I say plate, I don't mean around like a dinner plate. It's like a long little piece of metal, just about the width and length of the bone. And it has holes in it, and we can put little screws into the bone to hold it. So those as supplemental fixation have been very helpful in the more difficult cases, and also to minimize the immobilization and pain that the child requires after the surgery. So the type of surgery, the type of rods, the type of implant is dictated by the bone itself, first of all, the size of the bone, the shape, and what you're trying to achieve. Age, to me, is not the deciding factor.
Right. Okay. Great. Thank you. What are some of the complications that you might see with, rodding surgery, for example?
Well, unfortunately, when you're operating on softer bone, which children with OI generally have, the most common complication is that the bone can break even though there's a rod in it. We do see this, a child with a severe fall can bend a rod, they can break a bone. Now, fortunately, the rod does add stability or strength to the bone, so even if a child does have a fracture after rodding surgery, usually it's a much less severe fracture and is more easily treated. So that's one of the benefits of the rodding surgery. The rods can move in the bone. These rods can migrate as the child. Migrate means move out of the bone and become noticeable under the skin, and require surgery to replace them or reposition them. That's unfortunately happens now and then. So those are some of the complications of surgery. And of course, any surgery can have the risk of infection, for which the doctors give antibiotics to try and minimize that risk. That's pretty routine now. So the infection risk is extremely low in children with OI, fortunately. And bleeding is in major surgery. There is some blood loss, so we often will need a blood transfusion in the children who have more extensive surgery. That's not uncommon to do. That's not a complication, but it's a planned part of the surgery. But bleeding is an issue sometimes with the children. Any other more risky surgical complications like damage to nerves or things like that, extremely rare in skilled hands, but always possible and counsel the patients for.
Great, thank you. You mentioned upper extremity surgery. Can you talk a little bit more about that? Because I think, I know that we at the OI Foundation are getting more and more calls about that type of surgery. So are we talking surgery to help kids ambulate, with their wheelchairs or scooting, as you talked about, or what is the goal of the upper extremity surgery?
Yeah, that's a wonderful topic. It's actually my favorite topic. When I started in working in OI surgery years ago, we only operated on upper extremities if they were almost completely functionless. If they were so breaking that the kids couldn't use them, we'd try something. We've come a long way since then. We've appreciated the need for upper extremities use in computers, in daily life. So now I am much more prone. One of my most requested surgeries is for upper extremity surgery, and to straighten the upper arm bones or the lower arm bones to help position the hand in space so the child can use the hand for a more functional way. So usually to decide on this, we ask, is it a fracture problem? Is the child fracturing too frequently? If they are, that's an indication. However, if the child has limited function using the upper extremities that we think we can improve their activities of daily living or their incorporation into society for jobs, computer use, etc., upper extremity surgery can be considered for that, to improve the hand function. So helping, it's become one of my mantras of helping position that hand in space so the child can use it. And I'm doing more and more, and it's a little more sophisticated surgery, but it's proven that there is a lot of potential for that to help improve a child's life.
Yeah, that's exciting. That's very exciting. Can you talk a little bit about the rehab after? Let's talk about maybe a rodding surgery for a femur. I mean, what's the rehab like? How long? What does it entail? Okay.
Well, for a younger child, I'll give you the general schedule, and then I can maybe mention some caveats or some things I'm learning as I go along, because you continue to learn in this field. The general, if I do lower extremity surgery, generally I'll do some form of immobilization of a cast or a splint for the child's lower extremity for a total of about 6 weeks. During the first 3 weeks of that time, we keep the casts kind of on to let the pain go down, let the healing begin, the bone to start to heal. After about 3 weeks, what I'll do is I'll remove the cast or the splint to allow the child on their own to start active motion of the extremity. At this point, I generally don't introduce physical therapy to that extremity, but I let the child actively use it just to begin their rehabilitation, regain their joint motion, work on joint strength. See, at this time, at about 3 weeks, the bone is strong enough for the child to move it, but it's not strong enough to put any stress on it, so I don't usually allow weight bearing at that point. But by about 6 weeks, we can progress, we can discontinue our cast or splints approximately that time, and then begin physical therapy. Usually, I'd like to begin in water to minimize the effect of gravity and to begin the weight-bearing process as the child is able. And of course, this depends on the child's ambulatory ability.
Okay, great.
Now,
so we have. Oh, go ahead. I'm sorry. Go ahead, Dr. Kruse.
I was just going to say some interesting things that I'm learning about that is first of all, I over the years, the spica cast is the standard method of immobilization, and I personally really don't like spica cast, as I'm sure no patient does. So we've been working here with different forms of immobilization, modified splints, modified cast, new casting materials, things like that. And it's a very interesting journey because it's the spica cast itself is for the lower extremity. That's a cast that goes up above your abdomen, maybe up to your nipples, and it immobilizes your whole lower extremity. Really is limiting and hard to care for, and it's certainly not fun to be in. So we try to minimize that. And I'm finding actually that I can do splinting and softer splintings and let the child have some mobility. The interesting thing I'm finding is that there's generally kids who need the security of that rigid cast, and there's children who need to be able to feel they can move a little bit after surgery. So it's very interesting because this goes back to what I was saying about personality. The personality of the child is coming out in the surgery. So I'm finding now that I'm having a preoperative discussion with my patients on what form of immobilization. Do we need a lot of rigidity? What will make the child feel best? So it's an interesting journey in that I'm developing a more individualized approach as we go on to the postoperative immobilization. And going along with that is also we're developing an individualized approach to the child's postoperative pain control. Very important. I find children respond differently to pain medicines far and away, and we really depend on the parents helping us out. And how do they respond to this? What do they need? We try to plan that preoperatively, and we have a pain team following the children. And I'd love to say we've controlled everybody's pain perfectly, but unfortunately, some people need to have adjustments of pain medicine in here, and it's been a learning process as part of that postoperative course in rehab.
It's interesting you mentioned the pain management. Again, we get a lot of calls here at the foundation about pain management. And you said you had a pain team. Is that someone that meets with the family and the child and you before surgery, or how does that work?
Well, some of our patients come from a distance, so I can't say they meet specifically with them, but usually once our pain team is on board, if they know I'm doing an operation and it may be a severe one, they'll try to plan some preoperative pain medicines with the family and try and discuss. Generally, if the child's had previous surgery, we definitely review what worked and what didn't for the child before, because different kids require different pain medicines. That's clear. So that information is we try to gain beforehand. We are using preoperative medication. There's a medication called Neurontin, which is a nerve medicine, but it seems we're using it routinely and trying to minimize the postoperative pain, and it seems to be helping. So we're giving some different preoperative medicines now too. But the pain team consists of nursing who are practice nurses who are experienced in pain control, and it's supervised by an anesthesiologist who's in charge of the team. And they follow the patients during their hospitalization here.
Got it. That's great. So you see children and adolescents up to 18, 21 at your hospital. What do you see as you follow some of these kids throughout the years? What are the challenges of surgeries that they've had it very young, and as they grow and get older? Do you see any anything common that you see among the patients you see?
Again, it's a mix. Most of the children, the rods, if they have a rodding surgery, it can last them quite a few years. And I have a good number of patients, 5 or more years, the rods are in place and they just expand. But one of the things and sometimes they do, in fact, very frequently require, as you grow, to have the rods replaced to put bigger and stronger ones in. I mean, I see that a lot. So one of the things I do see is as the kids get much older, stronger, and more active, they actually can fall and bend the rods if they get really aggressive or have an accident or something. So some of the problems we do see are the rods get bent and they have to be replaced also, unfortunately. But I'll tell you what, most days the improvement is far outweighs the risks. I mean, I just have been very, very happy with, and I hope my patients are happy, with their surgery. They seem to function just much better. The thing I've noticed the absolute most is the patients who come from a distance. If they have a severe fall or something with a rod in place, most of the time the fractures that occur in the bone are very mild and don't even require immobilization. So the rods have helped in that way too. And that seems to be holding up long term.
Excellent. Well, is there anything else that you would like to talk about, Dr. Kruse? This has been wonderful. A lot of information shared in a short amount of time, but I'd love if there's anything else you'd like to talk about. We have a couple minutes left.
Yeah, what I learned, I'll tell you what I learned the most from, and this is just very sincere. I learned the most from talking to the families preoperatively and postoperatively. To be very transparent, I learned from the pain medicines I gave, the pain medicines I should have given, the splints I used and the splints I should have used. I have really learned that I have to talk to that family before. We have to come to an agreement because most dramatically, some splints that I thought children would love, some children loved them, some children didn't. So I'm learning over the individual, just dealing with the families is much more important. And I urge all families to, if their doctor doesn't ask this, volunteer the information. The second thing I've learned is this surgery is not something that should be done by the casual surgeon. These children need specialized centers, so it's important to ask your surgeon if you have experience doing this surgery, because it can be absolutely wonderful or it can be very complicated. So I encourage families to make sure they're comfortable with their surgeon and their surgeon's comfortable with them. Those are things I've learned that I think are very important. My current interest is primarily in supplemental fixation. I'm finding more and more ways that I can surgically stabilize bones and minimize my casting. And I'm working very hard on some alternative casting techniques so we can avoid the rigors of casting. I don't like casts. So.
And I know your comment about making sure that your surgeon is comfortable and experienced. If they're not, what would you suggest that they, certainly as a member of the Medical Advisory Council, your information is on our website here at the OIF, but what other things should they do? Should they call us, or what's your recommendation?
Yes, I think calling the OI Foundation is a good first start. In fact, I often recommend that because we just received an email the other day of a family who was getting care somewhere, and it was an email that the family wasn't really sure their care was good. And the mother actually put out a kind of an email to us saying, what should I do? I think had that mom known about the OI Foundation, and for some reason she didn't, I think your repository of information is wonderful. At least you can give them more direction. This mom was just like searching. So I think calling the OI Foundation is a good thing, and I think that's something we have to strive for, a good repository for information for the patients.
Excellent. And just so our listeners know that you can visit our website at www.oif.org And, our Medical Advisory Council members are listed along with Dr. Kruse. Lots of information on our website, so we encourage people to visit our website often. Well, Dr. Kruse, this has been terrific. Thank you so much for giving us this valuable information. It's been wonderful. I can't thank you enough.
Can I close with one comment?
Absolutely.
It's a family affair.
That's a lovely closing comment. Yep. So thank you again, and we'll look forward to next month's podcast as well. And thanks again, Dr. Kruse, for your expertise.
You're certainly welcome. Enjoyed it. I hope the information was helpful.
Thank you.